So it is the best available device for absolute lung isolation. Next, coming to the various difficult airways and in children's. Selective lower lung isolation is this blocker. However, there are positioning is required. Also, bronchoscope is very essential for positioning this bronchial blocker. There are endobronchial tube which are longer than regular ET tube and short curve for lung isolation. Bronchial tube which is easier placement in patients with difficult. The double lumen LTs are suggested Arlen's and Jorg. The central shaft of the DLT is ellipsoid, contains the septal device segments. The minimize the turbulent airflow. So DLTs essentially consist of two endotracheal tubes bonded together. One lumen is enough to reach the mainstem bronchus. The other is short and distal trachea. At the proximal end of each is a standard 50 mm ET tube adapter, and it is attached to a short length of tubing which creates a Y shape, and it permits independent attachment for ventilatory apparatus. We can clamp this shape connector during one lung ventilation, open to atmospheric air, and thus we can also do the suctioning. Now coming to the double tubes, the distal end of the DLT, the shaft is surrounded by stable cuffs. Lung separation by these two cuffs. Protracheal cuff located in the stem bronchus. About the right sided DLT, the to the tracheal bifurcation. The orifice of upper lobe bronchus is around 1 to 2.5 centimeter from the carina. The right upper lobe bronchus. A right side DLT ventilation port or endobronchial side. This is in order to face of the right upper lobe. Now, on the left and right, we decided DLT because it is easier to placement. Left main because it's short 2.5 centimeter. Now, it is in left side DLT, so the risk of malposition is less. Where in their margin of safety is very narrow, so there is high risk of displacement. So there is high risk of right upper lobe obstruction. So to counter this, there for the right up left side and in the right sided DLTs are used when the left bronchus is not usable. Commonly, it's seen the left mainstem bronchus. So in a short, there is in the right sided DLT and right side should be precisely placed. It has additional carinal curve, which is the third curve in auto position at carina, which reduces side DLT. There are distal end, which provides real-time continuous visualization, and there is no bronchoscopy for positioning. Next is the Naruka easy insertion. It is specially facilitated, especially in the difficult airway scenarios. Bronchial tube, which has two ventilation. Next to the Onco DLT, which has well-forced flexometric structure. Next one is the Carlen's DLT, which has a special carinal hook. It helps in also obsolete now. Next one is the Papworth biventilation. It is independent ventilation channels with special connectors and allows differential strategy. Course. The main types are Cohen, Arnott, and they differ mainly in size carina. So some important practical points. ET tube size varies. Like Arnott allows use with small 4.5 millimeter. Murphy size is present larger size of Arnott tube but absent in Fuji and EZ. Central lumen size affecting suctioning and CPAP ability. So selection of bronchial blockers depends on the ET tube size for lung isolation. Now coming to determination of silent size, left-sided DLT is commonly placed as right-sided DLT. Next one is the distorted anatomy of the entrance of the bronchus, like there is external intraluminal. And if there is side surgery involving the left, for example, left lung transplantation, left-sided tracheobronchial disruption, or left-sided pneumonectomy, or left-sided sleeve resection. So what we commonly follow, if in female, if the height is less than 160, we'll go for 5 or 37. It's very less, like less than 152, then we have diameter on 32 size of DLT. In case of male, if the height is less than 170 centimeter, then size of DLT. If it's more than 170, we go for 41. If it's very less, like than 160, then we can consider 37. The fiber optic, which is, but it can be accessible.
Is much complicated and much difficult. And there are a lot of publications determination. Here is one publication where the researchers and the cuffs using by calipers, they have inflated both the cuff and again deflated it, and then compared it diameter and left main bronchus. And they concluded that when we use this DLT and take the measurement as an inflated cuff, then obviously the tracheobronchial trauma during the placement is less. In this method, we followed by isolation. Researchers, they have used multiple parameters. In they use the tracheal diameter. In CT, they use recoil diameter, left main bronchus, posterior, and transverse chest diameter. But the problem is that day-to-day practice scenario, we use the DLT along the height of the patient, along with the gender of the patient. But they compared it with the ultrasound guided cricoid diameter and CT guided cricoid. Concluded ultrasonography and computed tomography guided measurement cricoid cartilage diameter is an effective method to compare the conventional. Confusion increases. What to do? Another reviewer which several all the for determination of DLT, and they conclude? They conclude if we use the height and the gender of the patient, we do conventionally required diameter and the left main bronchi, then is almost the perfect size of the tube. And we are following in this particular patient almost the, that means we use left main bronchus diameter one slice below the carina. We use the tracheal diameter one slice above the carina, along with the height and gender the thymectomy patient, height of 2 centimeter and 37 left DL. Into the placement techniques, we always or video laryngoscope to use the tube and during place anteriorly, and we place it as the lumen crosses the vocal cord clockwise or anti-clockwise. This placed it left sided, and then till we get the resistance, we push the tube. Depth of insertion is usually 12 plus patient height. Anchor DLT plus. This tube has got a that is green colored here, and it, after placing the laryngoscope, we inflate, and it automatically helps the placement of tube. As usual. Coming to Vivasite DLT, in Vivasite DLT, there is a camera, and this camera is video scope. So after suctioning the, place the tube with a scope, and then inbuilt camera helps us to put the tube on the left side or on the right side, and the are usually, this tube is pretty costly and it is not easily available. But using some principle, nowadays we place and show it how we do it. We place the tube inside the trachea, and when we carina, we deviate the scope to the interior. In this case, this is, and then we rotate the tube to the clockwise to the fiber scope, and the position upper bronchus as well as the middle and lower bronchus is also checked. We tube in situ, and thereafter coming to placement scope is not available. We can confirm the position of the tube by seeing inside the carina is more or less at the second intercostal space, and the left, this is the left sided DLT. We can place one obstacle over the heart, it with the left is more or less placed at. Next, we further confirm placement of the tube. We attach the attachments. Just then we for checking, and we check by auscultation. In one, we the tracheal cuff, and then we see the bilateral air entry. The bilateral air entry. 2, we close with a tracheal lumen. Closing the tracheal, we put the blocker in the lumen, then open the vent, and again here we see this is the left sided tube, so we can auscultate the the air leak. Now in step 3, bronchial cuff is gradually inflated till this air leak stops. We can check either by auscultation. Now the cuff can always be measured by the. Now in step 4, we just do the reverse. We release the previous blocker in the intended lumen, left side of this, and then again we can see only other end is there. Now coming to more, that is the with the bronchoscope. In left-sided placement, we put the bronchoscope through the tracheal lumen, and then after reaching the carina, rotate the tube 90 degree to the right or the clockwise, and we can see the tube placed on the left, and we are reaching on the right side, and then we can see the 3 apertures separated by right main canine, right, and see the middle and lower lobe bronchus. Place the tube further, slightly. The cuff is here, and when a chink of blue available here, and when we inflate that bronchial cuff, as you can see there, then we quickly take out the, again put up, and we can see cuff area, and then we try to negotiate the bronchoscope out of the tube. Sometimes it is difficult here. Tube position inside the, but we will try and the up lingular, and if succeed, then we try to go in the lower. But altogether in the left side, we can see there are 2 apertures separated by the left carina. So that it is the left-sided left main bronchus, as well as there is of the tube. Going to the right DLT, the same method. First we put through the to see to reach the carina, right side, and rotate we anti-clockwise to left with 2 apertures divided by septa, left going into the bronchial lumen, and then again we will try to identify the right main, the right main bronchus, and then we come and see the right upper aperture and the tube aperture is correctly aligned or not. If not, then we have to align it again, and then the formation of the tube position is finalized. Coming to some troubleshooting during the DLT placement. First, the left side DLT placement. In scenario A, of the is available by view. So in B scenario, cuff, the blue color, is to see when we in you landed up in C scenario. In this scenario, you can ventilate both the lungs. You can ventilate one when patient. Same situation can turn out to be this when the patient is in lateral. Because the patient position is changes, every chance that this cuff is of the left main bronchus. It's in this scenario, but left lung ventilation, during the left lung isolation, there will be concentric and isolation. In the next scenario, the left main bronchus and the both lung, both lung ventilation, and if you still try to trauma, and in lung E position, you took the tube out, but again it is inadequately taken out, and that's during both lung ventilation it is possible. But during one lung ventilation, you will get high airway pressure. So one is the ideal scenario. You have to, in scenario A, this is the correct placement where you can blue cuff and with the right here floating trachea and still to be put it down. In scenario C, the right DLT placed too far into the right main bronchus, and that's why the right upper bronchus is not being not get heard the sound at the right upper. You will feel the air pressure is inadequately, rather it is very high. Coming to the last scenario, the left DLT is accidentally placed in the, so that is for the next segment. I would like to Dr. Oberu, please.
Anatomy of the respiratory system, various lung isolation them to the lung, right? Is actually associated with spectrum of lung injuries, barotrauma, polytrauma, atelectrauma, and biotrauma. This is as per literature. So the incidences can vary to 2 to 4% for lung resection surgeries, and for pneumonectomy it can to 12%. But mortality can also be as high as literature is shown here. Now, so what we need to adopt is a protective ventilation. How we do that? Tidal volume around 4 to 6 ml per kg for one lung, and around 4. Both are really increase the inflammatory. Also need to adjust the respiratory rate accordingly to maintain a level so as to maintain the PCO2 near to the baseline and not too high. And the P 5 to 10 centimeter, whereas in restrictive lung disease it needs to be more than 10, and in bronchospasm less than. The inspiratory expiratory rate for normal lung is maintained at 1:2. For restrictive lung disease 1:1, and for bronchospasms it may vary from 1:3 up to 1:4. The air pressures should be limited. The peak air pressure should be restricted less than 5 centimeters of water, and plateau pressures less than 25. The FiO2 at time in troubleshooting we need to increase, but we need to minimize FiO2 so as to maintain saturation percent. And of course, for now, complications. What are the major complications? Intra-op, most commonly what we face, many of us have faced it. And post-operatively also we can have tracheobronchitis or tension pneumothorax or neurovascular injury. How to the management? We must predict what can happen. We must know it. So also, which has complication. So coming down to the individual complications. So hypoxia first. How can that one ventilation? If the pre-existing PO2 itself is low, if we are actually ventilating the left side lung because it has lesser segments, if the forced expiratory volume in the first second is already high, or if the patient is being operated in a supine position and one lung, more chance of hypoxia. How we can, as already said, lateral is more preferred. supine, and for the recruitments and also to minimize the compression. This is an ideal with which we can actually do the recruitment hypoxia conditions. And how do we manage it actually? This algorithm is very important. ECTs who are attending to memorize it properly because we are having hypoxia first and 400% and then gradually titrate it so as to maintain an whether the lung isolation necessary to remove any blood available. We must induce the surgeon immediately that there might arise a situation of the both ventilation. I mean, I can also ask them to reduce the traction in the surgical field. Uh, how to recruit these lungs? Independent lung or jet ventilation, or even can field and oxygenate through the suction port. For the dependent lung, we need to recruit it and give the heat and fusion. The oxygen delivery can be improved by vasopressors, improving the blood pressures, and if it is to give trans improve the hemoglobin, we can access from the volatile anesthesia, total intravenous anesthesia down on the blood pressures are low, then on the local institutions that are going on. And if it's a severe hypoxia, of course, then we have to turn to both lung ventilation and, of course, check all the positions and all. Then, how do we improve this perfusion? We can use the vasopressor. We can use the nitric oxide. Can be communicated, and they can be partial or complete clamping of the pulmonary trunk on the operative. And if nothing, the last resort, we can turn up to the extracorporeal membrane oxygenation and cardiopulmonary bypass. There are other complications also. This is how we can recruit with giving the position to the non-dependent lung if having the procedure. So, coming to the other complications, after the surgery, there can occur certain life-threatening complications. We understand that this is emphysema when the patient has anticipate what all can happen, but there are various which can help, like X-ray, USG, CT, which might actually reveal a tracheobronchial rupture. The etiology due to the injuries during surgery or placement of the devices, and to deal with is to preserve for the patient. We place a supraglottic airway device and pass the flexible bronchoscope to find the extent of the injury. Then we place the tip beyond that injury and railroad the tube required ECMO or bypass. If patient is suddenly developing tachycardia, hypotension, they chance of which is also revealed by each echo. Or the reason might be the pneumonectomy. The left patient is right obstruction. Important is not to place the surgeon side and avoid any negative suction from the. Can also have features of hypotension, tachycardia, desaturation. As revealed in a USG, we can find tension pneumothorax developing. That is population. There is absence, or if the is actually not functioning properly, immediately we need to do a needle thoracostomy. Test tube insertion needs to be done, if not already done. Next, come to the another thing is already Akash has actually explained this. The neural padding should be done to prevent this and bend. For catheters, when I was young, also I was very about the basic anesthesia. It's a but remember hot days, but you should always carry on your hard work and grab all the opportunities whom to call for help. So anesthesia is a teamwork together. If we are working, let's put forward.
Now we can take this.
Yeah, thank you so much, Dr. group and the whole Jaya Madam and the PGTs for excellent academics today. So, executive council member just to check that whether they have question.
No
So everyone
question.
raise their hands.
Yes. Still now. Yes, Devananda
Yes.
wants to.
You are muted.
Devananda.
Yes. Hello, myself
Yeah.
Devanand. So first of all, thank you all, Dr. Avirup, Varsha Prabhu, and dear. So it's been very learning session. So I have few question or maybe some. Firstly, in cases of
You are going for when patient is not optimized and patient has significant muscle paralysis or significant disease. That means patient did not receive any IVIG or the plasmapheresis kind of thing. They easily the patient with inhalational with the yes, for medical purpose it is risky that how the patient to take pyridostigmine in the morning on that in the morning if you allow that, so it may have some chances the patient movement and these things can coma and that you sit up along with the inhalation or you can use the muscle relaxant as well. Remember that the patient all you want do extubation at the ICU. So these all
the approach is conventionally as it is the toward 110 dose of and standard approach.
yes you can go. Yes.
My second question is mention the or in that case of the choice anesthesia was written that like neuraxia is not a choice in C-section. It can be a analgesic epidural insertion.
That is the thing. That is the kind of he wanted to say.
Should be part choice.
I would like to add here.
GA is preferred.
I would like to add here
Yes,
what Dr. Akash wanted to say is that we are not going to give thoracic neurag to conduct section. We need at least T4 to T6. That may not be, we are giving spinal at the level, but the effect that we want, it must reach next level. That may not be by patient. There is significant respiratory muscle weakness that may not be well tolerated by them. And in those, GA.
Like we are
severe respiratory muscle weakness, the patient may not tolerate a block level of T6, which is desirable in patient. Specific general anesthesia.
Another kind of footnote
can very well be given. It may be difficult to give general anesthesia in patients where to insert DLT VATs probably will need to give neuromuscular blockers, but it is very much evidence-based that we surgeries like laparoscopic surgeries and surgeries like cesarean section, muscular
to move on for the next. So
What is
before
your-
that, Jacob sir.
Well,
audible.
I just add one thing. Of the operation, various disadvantage operation and the muscle movement will be it is preferred to stop the treatment.
Yes, Saikad, usage various types. You can say some they completely stop in the morning and even prefer suggest.
Yes, yes. And the thymectomy is asthenia gravis. Thymectomy is not indicated. There's few indication of thymectomy, and it is also children under 12 years, and after 50 years there is no role of thymectomy. Okay, this is just a tip. একটু স্কোলিন আর ইটিদের জন্য বলছি, and কোনটা কেন একটু ইলাস্ট্রেট করে দিলে ভালো হয়। সাপোজ why the schooling is action of the schooling is prolonged, non-bipolar.
Simple question. Your sensitivity is go for remifentanil setup. Most of the times we don't get those drugs. So how can we use opioids in case of myasthenia gravis? The sensitivity is increased. It is the physiology behind it.
Not all opioids are getting before that. Cholinesterase level, and that time remifentanil will act. So other sensitivity increase. The mechanism not yet described, but it is said that the effect of sensitivity of effect of fentanyl is slightly more. But the pseudocholinesterase activity and remifentanil is pretty mentioned in the literature.
Okay, thank you, sir.
It is preferable to avoid all the drugs that will depress respiratory center. So we avoid the long-acting opioid.
Okay, thank you, sir.
Okay.
Refer to Kosturi.
Right. Am I audible? Okay. Great. First and foremost, at the outset, I would like to congratulate very clear, lucid, and very confident. Well done, Akash. Keep it up. And thank you, Dr. Orgo, Dr. Jaya, Dr. Shantan, and Dr. Abhirup for emphasizing and in detail highlighting salient aspects of this case in a very vivid manner. Now we move on to a quiz based on whatever has been discussed in the last 1.5 hours, and we'll be using the My Quiz platform, right? So that we just try to take a quick review of how much has been our understanding and from our memory what we can take in 20. Question will be getting 20 seconds. First and foremost, we have shared a QR code. I would request to scan from your mobile, participate. to this quiz, right? We will be giving so that all of you can scan the and log in. You will be needing a separate device to log in, because if you log in, yeah, and I request you to log in with your original name, because this quiz will be having prizes announced by in the beginning of the session. So I would request you to please put in your original names. So we'll be waiting for 5 minutes, and the quiz has rule that it will be fastest finger first. So the person who gives the correct answer time will have their the leaderboard will be shown. So that makes it more interesting.
Sorry, madam, the quiz is other participate, but prizes will be distributed.
QR code visible to everyone. We are still waiting for wait for another 2 minutes. Yes, we should start now. Delegates are ready to join. So Dr. Orgo, is it okay? Can we start?
I think so. We will start.
Can we start with the quiz, Dr. Orgo?
Yes, yes, start.
Okay.
10 pairs are there. You start.
Patient with myasthenia gravis has weakness, improves after vibration, improves with repeated use, is constant throughout the day, or worsens with repeated use. Is worsens with is the characteristic of myasthenia gravis, that is fatigability with muscle use, isn't it? Okay, so we have the Payal Mitra at the top with the first answer. Shows increased myasthenia gravis patients. Of course, that's an easy one. So that's the reason the bolus dose, usual bolus intubating dose that we give to normal patients. So now muscle relax procurinium is the answer. If we go on to the next one. Amigo, who is Uncle Cactus? Pre-operative predictor of post-operative ventilation. Yes, vital capacity. Dr. Akash presented during his presentation. He specifically mentioned that capacity of less than 0.9 liters leads to higher chance of post-operative ventilation.